Hello and welcome back to the Deep Dive. Today we are shifting gears just a little bit. We aren't just exploring a topic. We are stepping into the shoes of a postgraduate student preparing for a major hurdle.
The big one.
If you are an MD anesthesiology resident, and specifically if you are targeting the Gujarat University exam format, this session is designed entirely for you. We are tackling the absolute superstar of the modern pharmacopoeia.
It really is. I mean, you could argue it's the standout drug of the last 2 decades in our field. It has, fundamentally changed how we approach sedation.
We were talking, of course, about dexmedetomidine, and our mission today is very specific. We have pulled from the giants. We're talking Millers, Stolting, Morgan and Mikhail, Katie Tripathy, and, of course, current ICU protocols to create the ultimate audio review.
Right.
We're going to structure this exactly like a high-yield exam answer.
That's precisely the goal. We have a 15-point roadmap. We're going to take you from the molecular structure all the way to the specific Viva traps that examiners just love to use to, trip up candidates.
So this is very much a masterclass.
We are treating this as if I am the senior faculty and you are the student who is about to sit down and write a 20-mark long answer on this very topic.
Okay, fantastic. So grab your notebook or just visualize the headings as we go. Let's jump straight into Section 1, Introduction and Exam Framing. If I open my exam paper and the first long question is dexmedetomidine, how do I start? How do I grab those first few marks immediately?
You need a strong, precise definition. Don't be vague. Don't just say it's a sedative.
Oh.
You define dexmedetomidine as a highly selective, specific alpha-2 adrenergic agonist. That's your opening line. Then, for the bonus point, you mention its structure. It is the S-Enantiomer of medetomidine.
S-Enantiomer. Right, and what about the chemical class? Does that matter?
It does. It shows depth. It belongs to the imidazole subclass. Now, this is important because it establishes its lineage, its family tree, so to speak.
Okay, so it's related to something else we know.
Exactly. It is chemically related to clonidine, which is also an imidazole derivative. But you have to frame dexmedetomidine as the evolved, high-potency, much more specific version.
So why is this drug such a game changer? I mean, why is it showing up in exams constantly, year after year?
Because it solved what you could call the holy grail problem in anesthesia and critical care.
Which was?
Historically, sedation was synonymous with respiratory depression. It was just a given. If you gave propofol or midazolam or any opioid, you depressed the patient's respiratory drive. You had to be ready to support their breathing.
Right, it was a trade-off.
A necessary evil. Dexmedetomidine breaks that rule. It provides sedation and analgesia without causing significant respiratory depression. And that's the clinical hook for your introduction. That's the revolutionary part.
And in terms of the exam pattern, you mentioned a 20-mark question.
Yeah.
Is that the most common format?
It is classic material for a 20-mark long answer. It's perfect for it because it lets you discuss physiology, the autonomic nervous system, pharmacology, and clinical medicine all in one neat package.
So it tests multiple domains.
Absolutely. But you'll also see it as a short note, and it is a huge favorite in the Viva Voce. An examiner can start with dexmedetomidine and then pivot to asking about anything from G-protein coupled receptors to airway reflexes to management of bradycardia. It's a gateway topic.
Okay, that makes sense. So let's move to Section 2, Pharmacology. You've labeled this very high yield.
This is non-negotiable. If you mess this part up, you fail the question. It's that simple. We need to break down the mechanism of action in quite a bit of detail.
So this is where we show we're not just memorizing facts.
This is where you show your depth. First up, selectivity. You have to quote the ratio. You must. Dexmedetomidine has an alpha-2 to alpha-1 selectivity ratio of 1,600 to 1.
1,600 to 1.
Yes. Some textbooks might quote 1,620 to 1. Either is fine, but you need to have that number.
And just for context, for a comparison, how does that stack up against clonidine?
That's the perfect follow-up. Clonidine, its older cousin, has a ratio of about 220 to 1.
Wow. So that's not even close.
Not even in the same ballpark. It's a massive leap in specificity. This is why we can call dexmedetomidine a full agonist at the alpha-2 receptor, whereas clonidine is more a partial agonist.
Right.
And that specificity is why we get such clean sedative effects without as many of the unwanted alpha-1 mediated side effects like hypertension.
Okay, so let's dig into those receptors. It's not just alpha-2 in a generic sense, is it? There are subtypes.
Correct. For a postgraduate level answer, you absolutely need to distinguish the subtypes. It's not good enough to just say alpha 2.
Exotic.
We have alpha 2A, alpha 2B, and alpha 2C. Now, alpha 2A is found largely in peripheral tissues and on blood vessels. It's involved in mediating some vasoconstriction. But the real magic, the part we care about for sedation and analgesia, happens with alpha 2B and alpha 2C in the central nervous system.
And this brings us to, I think, the core of it all, the sleep button. We need to talk about the locus coeruleus.
This is the centerpiece of the mechanism. The locus coeruleus, which is located in the pons in the brainstem, is essentially the vigilance center of the brain.
The on switch.
Exactly. It's constantly firing norepinephrine to keep you awake, alert, and paying attention. Dexmedetomidine binds to presynaptic alpha-2 receptors on the locus coeruleus itself.
Presynaptic, that's a key word there, isn't it?
That is a key word. It's a negative feedback loop. By stimulating these presynaptic receptors, it tells the neuron to stop releasing its own neurotransmitter. It inhibits the firing of the locus coeruleus.
So you're turning down the volume on the wake-up call.
Precisely. Now here's the elegant part of the pathway. When you inhibit the locus coeruleus, you remove its inhibitory effect on another part of the brain called the ventrolateral preoptic nucleus, or VLPO.
Okay, so a double negative.
It's a disinhibition. The VLPO is the brain's main center responsible for promoting natural, non-REM sleep. So by turning off the wake center, you allow the sleep center to take over naturally.
That's fascinating. So it's not like a sledgehammer. It's more like flicking a physiological switch.
You've nailed it. It mimics the physiological pathway of falling asleep. This is why the quality of sedation is so profoundly different from the GABAergic drugs like propofol or midazolam, which just globally depress cortical activity. It's a much more natural-feeling sleep state.
Okay, that covers sedation beautifully. But it's also an analgesic. Is that happening in the brainstem too or somewhere else?
No, a different site of action. The primary site for analgesia is the spinal cord.
The spinal cord.
Specifically in the dorsal horn, an area called the Substantia gelatinosa. Dexmedetomidine binds to alpha-2 receptors there, and it inhibits the firing of nociceptive neurons, the pain-transmitting neurons. It reduces the release of excitatory neurotransmitters like substance P and glutamate.
So it's blocking the pain signal at the source before it even gets up to the brain.
It's acting as a gatekeeper for pain signals at the spinal level.
Okay, let's zoom in one more level down to the cellular level. If I have to draw the receptor mechanism in the exam, what's happening inside the cell when Dex binds?
Right. So the alpha-2 receptor is a classic G-protein coupled receptor.
GPCR.
Yes. Specifically, it is linked to a G protein, and the I stands for inhibitory. So when dexmedetomidine activates the receptor, the G protein goes on to inhibit an enzyme called adenylate cyclase.
And inhibiting adenylate cyclase drops the levels of cyclic AMP.
Exactly. The drop in CANMP, which is a second messenger, leads to two major ionic changes inside the cell. First, it opens G protein-coupled inward rectifying potassium channels. Potassium flows out of the cell,
Making it more negative.
causing hyperpolarization. The cell becomes more negative on the inside and much more resistant to firing and action potential. Second, it blocks voltage-gated calcium channels. If calcium can't get into the terminal cannot release its neurotransmitters.
So he's got hyperpolarization, making it harder to fire, and inhibition of neurotransmitter release.
Hyperpolarization and inhibition of release. That is the cellular mantra for dexmedetomidine. You say that, you draw that, you've got full marks for the mechanism.
Perfect. Now, let's pivot quickly to pharmacokinetics.
Yeah.
How does the body handle this drug?
Okay, so it follows a two-compartment model. It has a very rapid distribution phase. The distribution half-life is only about 6 minutes.
So it gets to the brain fast.
Very fast. It's highly protein-bound, around 94%, mainly to albumin.
And metabolism. Where does it get broken down?
It's almost exclusively hepatic metabolism. Extensive. It undergoes two main processes, direct glucuronidation and then oxidation via the cytochrome P450 system. The main enzyme to remember is CYP2A6.
And the breakdown products.
The metabolites are inactive, which is good. There's no active metabolite to worry about. They're then excreted, mostly in the urine, with a smaller fraction in the feces.
There is a concept here that's really important, especially for the ICU part of the exam. Context-sensitive halftime. Can you break that down?
Absolutely. This is a very common Viva question. The simple elimination half-life of Dex is about 2 to 3 hours, but that number can be misleading.
Why?
Context-sensitive halftime tells us how long it takes for the drug concentration in the plasma to fall by 50% after you stop a continuous infusion. It depends on the duration, the context of the infusion.
So it changes over time.
Dramatically. Because the drug is lipophilic, it accumulates in fatty tissues. If you run an infusion for just 10 minutes, the context-sensitive half-time is about 4 minutes. Very quick. But if you run that same infusion for 8 hours,
It's much longer.
it jumps to 250 minutes. That's over 4 hours.
There's a massive difference.
It is. And it has huge clinical implications. It means if a patient has been on a Dex drip in the ICU for 3 days, you cannot expect a rapid wake-up. You stop the infusion, and it's going to take hours for them to clear the drug. You have to factor that into your weaning plan.
Okay, that's a brilliant point. So moving to section 3, pharmacodynamic effects. This is what the drug does. We have a specific term for the type of sedation it produces, right?
Yes, and this is a buzzword you must use in your answer. Cooperative sedation.
Cooperative sedation. What does that mean in practice?
It means the patient appears to be asleep, very calm. But if you speak to them, maybe a little loudly, "Hello, open your eyes," they will open their eyes. They'll look at you, they'll understand you, they can follow simple commands, and then when you stop stimulating them, they just drift back off to sleep.
Which is completely different from propofol.
Totally different. With propofol or midazolam, if you rouse them, they are often confused, disoriented, or just, out cold. Propofol causes a kind of clouding of the sensorium. Dexmedetomidine leaves the cognitive sphere relatively intact upon arousal. It's a much cleaner state.
And alongside the sedation, we also have analgesia, anxiolysis, and sympatholysis.
Correct. The analgesia gives it a significant opioid-sparing effect. The anxiolysis is profound, and the sympatholysis is key.
What exactly is sympatholysis?
It's the reduction in sympathetic nervous system outflow from the brain. It reduces the circulating levels of catecholamines like norepinephrine. This is what blunts the hemodynamic response to stress, like laryngoscopy and intubation or the start of surgery. It keeps the heart rate and blood pressure more stable.
And now for the exam core point you've highlighted, respiratory sparing.
This is the most critical differentiator. This is its unique selling proposition. Dexmedetomidine causes a very mild reduction in minute volume, but, and this is the part you have to emphasize, it preserves the ventilatory response to carbon dioxide.
Can you explain that response curve for the listener?
Of course. Normally, as the level of CO2 in your blood rises, your brainstem's respiratory center detects this and drives you to breathe faster and deeper to blow it off. It's a steep, linear response.
A safety mechanism.
A vital one. Opioids completely flatten that curve. With morphine, CO2 can go dangerously high, but the patient simply doesn't get the signal to breathe. Dexmedetomidine, on the other hand, barely shifts that curve to the right. The response remains almost completely intact. The safety margin is just massive compared to other sedatives.
Got it. Okay, section 4. Systemic effects. Let's look at the cardiovascular system first.
Yeah.
This is often where students get confused because of the biphasic response.
Yes, and it's a great thing to explain because it shows you really understand the pharmacology. If you give a rapid bolus, a fast push of the drug, the very first thing you will see is hypertension.
Hypertension. But I thought it caused low blood pressure.
It does eventually, but the initial high concentration from a bolus hits the peripheral alpha-2b receptors on the smooth muscle of the blood vessels first. This causes direct vasoconstriction.
So squeeze first.
The vessels squeeze and the blood pressure spikes, sometimes quite alarmingly. It's a transient effect. Then, as the drug distributes to the central nervous system and the concentration in the blood falls, the central sympatholysis takes over.
And that's when the blood pressure falls.
That's when the sympathetic outflow drops and you get the more characteristic effects of hypotension and, very commonly, bradycardia.
So the key takeaway is that in the long run, for an infusion, it's a hypotensive bradycardic drug.
Correct. For a maintenance infusion, you should expect it to decrease heart rate and decrease cardiac output. And you have to be very, very careful in patients who have fixed cardiac output states, like severe aortic stenosis. They can't tolerate that drop.
What about other CNS effects beyond sedation?
Well, it reduces cerebral blood flow, or CBF, and it also reduces the cerebral metabolic rate of oxygen, CMR-2. It does this without significantly increasing intracranial pressure or ICP. In fact, it might even lower it slightly.
So it's safe for neurosurgery.
It's generally considered neuroprotective, or at the very least, neuroneutral. It's a very good choice for patients with brain injuries.
Okay, let's move to a big one. Section 5, clinical uses. This is marked very high yield. Where do we actually use this drug in the hospital?
Okay, number 1, ICU sedation. This is its primary FDA approval. It's ideal for short-term sedation in intubated, ventilated patients. The cooperative state makes weaning from the ventilator so much easier. You can assess their neurology, you can communicate with them, and you can even extubate the patient while they are still on a low dose of the drug.
What about procedural sedation?
It's perfect for what we call monitored anesthesia care, or MFC. Think of things like cataract surgery, pacemaker insertions, any procedure where you want the patient comfortable, calm, and pain-free, but you need them to be able to follow instructions.
And the classic Viva scenario, awake fiberoptic intubation.
It is the drug of choice for this, hands down. You have a patient with a known difficult airway. You need them breathing spontaneously while you navigate a scope into their trachea. Dex gives you the sedation you need for them to tolerate the scope. And this is a fantastic point to add in an exam. It also causes xerostomia.
Dry mouth.
Yes. It's an anti-sialagogue. It dries up secretions in the airway, which gives you a much better view with the scope. It's a helpful side effect in this specific context.
And awake craniotomy.
Same logic, really. The neurosurgeon needs to map the speech area or motor cortex. You need to wake the patient up in the middle of the surgery, have them talk to you or move their hand, and then get them to go back to sleep. Dexmedetomidine facilitates that transition incredibly smoothly.
You also see it used in regional anesthesia. How does that work?
It's a very potent adjunct. If you add a small amount of dexmedetomidine to the local anesthetic you're using for a spinal, an epidural, or a peripheral nerve block, it significantly prolongs the duration of both the sensory and the motor block.
And just a brief mention for pediatrics.
It's very widely used, though often off-label, for non-invasive procedural sedation. Think of kids who need an MRI or a CT scan. Instead of needing a full general anesthetic, a Dex infusion can often provide enough sedation for them to lie still for the scan.
Okay, great. Section 6. Dexmedetomidine and anesthesia practice itself. How does it interact with our general anesthetics during surgery?
It's a massive sparing agent. When you use it as an adjunct to a general anesthetic, it dramatically reduces the requirement for other drugs. It reduces the MAC, the minimum alveolar concentration of volatile agents like isoflurane or sevoflurane, by anywhere from 35 to 90%.
90%, that is a staggering number.
It's dose-dependent, but yes, the effect is profound. This allows for things like opioid-free anesthesia, or at least significant opioid sparing.
And the benefit of that is?
Less opioid means less postoperative nausea and vomiting, less respiratory depression in the recovery room, less consternation. It leads to a much smoother recovery profile.
And what about its role in TIVIA, or total intravenous anesthesia?
It's often used alongside propofol. The combination is synergistic. It allows you to use a much lower dose of propofol, which means less hypotension from the propofol and often faster, clearer wake-ups compared to using propofol alone at high doses.
Okay, let's move to Section 7. Role in special situations. We touched on the difficult airway. What about ICU delirium?
This is a really hot topic right now. The evidence, including recommendations in things like the ICU book, suggests that dexmedetomidine is associated with a lower incidence of delirium compared to benzodiazepines like midazolam.
Why would that be?
The thinking is that because it promotes a more natural sleep-wake cycle, it helps to reorient the patient and prevent that agitated, confused state. In fact, it's often used specifically to treat hyperactive delirium.
Interesting. And what about patients with obstructive sleep apnea, or OSA?
These are some of our highest risk patients. They are the ones who will obstruct their airway if you just look at them wrong after giving an opioid. Dexmedetomidine is often considered the safest sedative choice for them.
Because it maintains airway tone.
Exactly. It seems to maintain upper airway muscle tone better than other sedatives. It doesn't obliterate the respiratory drive. Now, you still have to be vigilant and monitor them closely, but it's a much safer option than the alternatives.
Okay, but it's not a magic potion without risks.
Yeah.
Section 8. Adverse effects. What are the big ones we need to worry about?
The big one, the most common and most feared one, is bradycardia. It can be severe. There are case reports of profound sinus bradycardia, sinus arrest, even a systole, particularly with rapid boluses in patients with high vagal tone. You must respect its vagomimetic effects.
And hypotension is the other side of that coin.
Yes, due to the central sympatholysis. It's particularly pronounced in patients who are hypovolemic or dehydrated. And, of course, you must remember the initial loading dose hypertension that we discussed earlier.
What about stopping the drug? Is there a withdrawal syndrome?
There can be. If a patient has been on an infusion for more than 24 to 48 hours and you stop it abruptly, they can get a rebound phenomenon.
Like what?
Rebound tachycardia, hypertension, agitation. It looks very similar to clonidine withdrawal. The best practice is to taper the infusion slowly over several hours.
Okay, that leads nicely into Section 9. Contraindications and precautions. Who should absolutely not get this drug?
The absolute contraindication would be a patient with advanced heart block, so second-degree Mobitz type 2 or third-degree heart block, unless they have a functioning pacemaker.
Because it slows conduction.
It slows conduction through the AV node. Giving it to someone with an already compromised conduction system is asking for trouble.
What about hypovolemia?
I'd call that a strong relative contraindication. Hypovolemic patients are surviving on a high sympathetic tone to maintain their blood pressure. Dexmedetomidine directly cuts that sympathetic tone. They can crash very, very quickly. You must fluid resuscitate them before you start the Dex.
And the elderly.
Dose reduction is essential. The mantra is start low, go slow. They have reduced hepatic clearance, and they are generally much more sensitive to the hemodynamic depressant effects.
Okay, Section 10 is an exam favorite. Comparison with other sedatives. Let's create a mental table for the listener. First up, Dex versus Clonidine.
Okay. Selectivity. Dex is 1600.1. Clonidine is 220.1. Efficacy. Dex is a full agonist. Clonidine is a partial agonist. And half-life. Dex is much shorter, 2 to 3 hours, which makes it titratable for an infusion. Clonidine has a long half-life of 6 to 10 hours, making it unsuitable for that purpose.
Okay, now Dex versus Propofol, the big showdown.
Arousability. Dex patients are cooperative and easily aroused. Propofol patients are not. Respiration. Dex spares the respiratory drive. Propofol is a potent respiratory depressant. Analgesia. Dex has intrinsic analgesic properties. Propofol has none.
What about amnesia? That's a big one.
Excellent point. Propofol provides reliable, dense amnesia. Dex does not. This is a potential downside. If you're using Dex alone for a procedure, you must warn the patient that they might have some recall of events.
Right. Section 11. Dosing and administration. Give us the numbers for the exam.
The standard textbook loading dose is 1 microgram per kilogram given over 10 minutes.
But let's pause here. What's the expert tip for both the exam and for real-world practice?
In practice, and you can say this in your Viva, we often omit the loading dose entirely. Or if we do give it, we give it very, very slowly over 20 to 30 minutes, precisely to avoid that initial hypertensive spike and the subsequent severe bradycardia.
And maintenance infusion.
The typical range is 0.2 to 0.7 micrograms per kilogram per hour. In the ICU, you might see it pushed up to 1.5 in some protocols, but for the exam, sticking to the 0.2 to 0.7 range is safe and correct.
And what's the golden rule regarding boluses?
Never, ever push it as a rapid IV bolus. I cannot stress this enough. It is not midazolam. It is not propofol. A rapid bolus is dangerous and is associated with severe hemodynamic instability, particularly bradycardia.
Okay, crystal clear. Section 12. Anesthetic implications.
Yeah.
Let's really clarify this concept of airway safety.
Right. This is a point of nuance that separates the pass from the honor student. Dexmedetomidine spares respiratory drive. The brain continues to tell the lungs to breathe. It does not, however, guarantee airway patency.
What's the difference?
A deeply sedated patient, even on Dex, can still have their tongue and soft tissues fall back and obstruct their upper airway. So while their brain is telling them to breathe, the air can't get in. You must still monitor the airway vigilantly with a jaw thrust, an airway adjunct, or capnography.
So spares drive does not equal safe airway.
Precisely. Hemodynamic monitoring.
What's the minimum?
It's essential. You need continuous ECG, non-invasive blood pressure cycling frequently, and pulse oximetry. For longer cases or sicker patients, an arterial line for continuous blood pressure monitoring is strongly recommended.
Okay. Section 13. Common exam questions and Viva traps. What is the examiner just waiting for you to say wrong?
The respiratory safety fallacy is number 1. If you say, there is no respiratory depression, so the airway is safe, you will be grilled mercilessly. You have to make that distinction between drive and patency.
What's another common trap?
The reversal question. The examiner will say, you've given too much Dex, the patient has a heart rate of 30, what is the antidote?
The trap answer is?
The trap answer is atipamezole. Now, atipamezole is a specific alpha-2 antagonist, but it is currently only licensed for veterinary use. If you mention it, you have to immediately qualify that it is not for human practice.
So what's the correct answer for humans?
The correct answer is stop the infusion. Then, supportive care. Give fluids. Give an anticholinergic like atropine or glycopyrrolate for the bradycardia, and if needed, a vasopressor. There is no specific reversal agent in clinical human use.
And the mechanism trap?
Forgetting the presynaptic nature of the receptor in the locus coeruleus, It inhibits neurotransmitter release. If you don't say presynaptic inhibition of norepinephrine release, you've missed a fundamental part of the mechanism.
Got it. Section 14, diagrams and presentation. If I'm writing this 20-mark answer, what should I draw to break up the text and impress the examiner?
You should absolutely draw the alpha-2 receptor schematic. Show the 7-transmembrane protein, show it coupled to the G protein, show the inhibition of adenylate cyclase, and then draw arrows showing the effect on the K+ and K++ channels.
And for the site of action?
A simple diagram of the brainstem, just a little oval. Label the locus coeruleus. Draw an arrow from dexmedetomidine showing inhibition. Then draw another arrow from the locus coeruleus projecting to the VLPO and show that inhibiting the LC leads to disinhibition of the VLPO. It shows you understand the pathway.
And the comparison table?
A 3-column comparison table dex versus propofol versus midazolam, for example, is mandatory. Compare them on receptor mechanism, sedation quality, respiratory effects, analgesia, and amnesia. It breaks up the wall of text and shows you can synthesize information clearly.
Okay, brilliant. Finally, section 15, summary and exam conclusion. Let's wrap this entire thing up with a high-yield recap for someone cramming on the way to the exam hall.
Okay, here are your take-home bullet points. 1. Selective alpha-2 agonist, ratio 1600.1. 2. Mechanism is presynaptic inhibition in the locus coeruleus for sedation and the spinal cord for analgesia. 3. Produces cooperative sedation that mimics natural sleep. 4. Its hallmark is respiratory sparing. It maintains the CO2 response. 5. Has a biphasic cardiovascular response, but the dominant effects are hypotension and bradycardia. 6. It's the ideal drug for awake fiberoptic intubation and for weaning patients in the ICU. And 7. Beware in patients with heart block and hypovolemia.
Perfect. Now give us that model conclusion paragraph to end the long answer with a flourish.
In conclusion, dexmedetomidine represents a paradigm shift in modern anesthesiology, effectively bridging the gap between sedation and wakefulness. Its unique pharmacological profile, providing cooperative sedation, analgesia, and sympatholysis with minimal respiratory depression, makes it an organ-protective and versatile adjunct, indispensable for the safe management of the difficult airway in neurosurgery and for the critically ill patient in the ICU.
That is a perfect summary. I feel like if you can write that and speak to all these points we've discussed, you are not just passing, you are topping the exam.
That's the goal. Visualize the mechanism, respect the hemodynamics, and always, always remember the clinical applications.
And maybe as a final thought for people to chew on, it's interesting how this drug forces us to redefine sedation itself. We used to think of it as just turning consciousness down, like a dimmer switch.
That's a great point, but dexmedetomidine suggests it's more about changing the channel from an active, vigilant state to the brain's own pre-programmed sleep state. It's a much more elegant approach.
A physiological intervention rather than just a chemical suppression. To all the students out there, especially those prepping for the Gujarat University exams, good luck. You have the content, now go apply it.
Go get those marks. You can do it.
That's it for this deep dive. We'll see you in the next one.